Pretty good. Yeah, it goes quite well. I don't know if it shows up on that one without showing up on this one.
Okay, that's fine then.
So then you can't use the whiteboard.
We can it's only at the end that I need the whiteboard. So we can have it down for the whole time.
Okay.
And then pull it up at the end. Is this on or is this muted?
It's on currently.
Cool.
Yeah. Yeah, it only works with that one. Sorry.
Yeah, it's all good.
Yeah.
Okay guys, we might get started. Sorry if my voice is still a bit crappy, still suffering from conventionitis, but a good example of what upper respiratory tract infection is all about. So respiratory history and examination. I found out at 9:05 this morning that I was doing it, so this is a very chucked together presentation, but I think it'll still be really useful. Is there anyone in this room who wasn't at either of my presentations on cardiovascular? Yes. Cool. I'm going to be touching on some of the things that I said there, but you should probably go through and read some of the slides in particular in detail, or just chat to your friends that were there about the key points. So this is the marking criteria. Familiarise yourself with it again and note where the bulk of the marks are in the history. Generally what we're going to be doing today, so the usual wash hands inspection, position, exposure, history, exam, thank you, and summary for every single system. History. So with every history, you always start with Socrates. The way that I've laid out today is by, wow, there's going to be a lot of typos like that, with looking at the important parts of each of the three main things you're going to be looking at in respiratory. So in respiratory, obviously you start with your introduction. So as I spoke about in cardiovascular, have kind of a set introduction that you do every time. Hi, my name is, how are you today? I've been asked to perform X exam, and describe in detail what it will involve as a method of starting your signposting, and then ask permission. Is that okay with you? You then don't need to ask permission every single time you do anything. You've already said that you're going to be removing their shirt as part of the examination. You've already said you're going to be asking personal questions about their home life. So they should be okay with that, and you don't need to repeatedly ask. So three main symptoms that you'll be looking at with respiratory at a phase 1 level is cough, dyspnea, and wheeze. So for cough, you've got kind of three differentials in your head. You don't have to have this level of knowing all of the differentials for all of the symptoms. If you'd like to know it, I posted a link to a folder on the year 3 page, and you can have a look at it, and it's kind of interesting to look at, but don't feel like you have to know it. But for cough, you're really thinking about respiratory tract infection, asthma, or COPD/lung disease. And that's kind of your main three differentials for everything respiratory at a phase 1 level. So the important things you need to know about a cough, you don't need to ask the site, obviously, you know where it is. Onset, so do you notice any particular pattern to when you get it? This might be things like, I only get it at night, I only get it when I'm playing sport, I've just had it consistently for the last 3 weeks, it's worse in the morning and gets better throughout the day. What does this sound like? So the way that you can kind of knock a lot of these nails in the head at once, as I said last time, is asking an open question at the start and then narrowing down to hit all of these smaller things. So can you tell me about your cough? And they'll say, oh, it started 3 weeks ago. It's kind of been going on constantly since. It's like a bit like barking like a dog, and it's a bit better when I'm nice and rugged up and warm inside. So you've kind of hit a lot of those things already, but if they don't describe those things, then you start going through these other elements of Socrates they've missed. So Does anything make it better or worse? Oh yeah, when I have like my puffer, it gets better, and then you're like, oh okay, I know what's happening now. So you should be able to really early on in the consultation know what's happening based on what they say, but you still need to ask the things so that the examiner knows what you're thinking and so that you're ruling out differentials. Do you notice it better or worse at any time is kind of similar to the pattern, but they might specifically say, oh, I only ever get this in spring, or it's worse at nighttime. What does a nighttime cough and wheeze suggest? Anyone know? Childhood asthma. Yeah, good work, Kish. And has it gotten better or worse since the symptoms started? So they might say, oh yeah, it's been constant. Oh, my son started getting this cough when he was 3 years old and wheezing a bit, and now he's 7 and it's really bad. It's kind of progressively gotten worse over time. Or nope, it just started and it was bad and it's been bad ever since. So that can help you to differentiate between things like asthma, which might progressively get worse, or between like a respiratory tract infection, which will generally get better. And does anything make it worse? Kind of already gone through that. And that's a lot of the does anything make it worse question is about going through triggers and eliminating different triggers, because usually you'll be looking at asthma or potentially COPD with some particular things that exacerbate it for that person. So what are some asthma triggers? Yep. Viral infection, yep. Yep. Those are kind of the big ones. Aspirin is another one that's really interesting. Sometimes aspirin can set off asthma. Laughing is a really sad one. Like, I had a friend who I used to go to the cinema with, and if we were going to the comedy, he was like, oh man, I left my puffer in the car. I have to go and get it before the movie starts. So yeah, triggers are interesting. Know kind of a couple of the big ones, but exercise, cold air, and nighttime are the main ones, especially in adolescents. So that's kind of cough in a nutshell. Then looking on to dyspnea. COPD is the main thing you'll be thinking about with dyspnea at a phase 1 level. Asthma is probably the second. And cardiac failure, it's a really weird, awkward one, but the faculty likes to put it in because they like to know that you can kind of transition between thinking about your different systems. So if you get dyspnea, it could become a respiratory history and exam, or it could become a cardiac history and exam. At a phase 1 level, I believe that most of the time they will say, perform a history and a cardiac exam, or perform a history and listen to the chest, perform a history and listen to the breath sounds. At a phase 2 level, they might be a bit trickier and say, perform a history and the relevant exam. So if you don't get the right history, you might not perform the right exam, but they shouldn't do that to you at a phase 1 level. If they do, tell the marker straight afterwards that it wasn't specified. But the markers will guide you. They want you to succeed. So with breathlessness or dyspnea, it's very similar questions kind of across all of these main symptoms. So do you notice any pattern to when you get it? What does it feel like? So this is an interesting one because they might say, oh, it's kind of like tight and it's like someone's sitting on my chest, or they might say, oh, it's like I'm being squeezed, or they might say, oh, it's like I can't get anything in and out of my throat. So that can help you differentiate between something like COPD or an upper respiratory tract infection. Does anything make it better? So again, they're very likely at this point to say, oh yeah, when I take my puffer, it's better. And do you notice it better or worse at any time? So when exercising, if it is kind of a respiratory / cardiac history that crosses over, you might find yourself going into, oh, you know, it's sudden onset, it happens when I'm exercising, and then you realize you're actually looking at cardiac failure more so than respiratory. Should be pretty clear from your stem though which one you're doing. But cardiac and respiratory are a bit tricky because they overlap a lot of the time. And does anything make it worse? Exercising, and then go through your asthma triggers as well. And then finally, wheeze. So infection is the main thing you're thinking about with wheeze. Asthma is the second. Asthma again because it was early and I was tired. And COPD. It's pretty much the same questions. With a wheeze, when you're asking what it sounds like, you can ask them to kind of like show you, and they go, or they go, and so you can tell if it's like an inhale or exhale wheeze. Anything make it better? So medications or resting are the main different ones there. Do you notice it better or worse at any time? Better or worse since the symptoms started? And does anything make it worse? So those are mostly the same for all of your 3 main symptoms, but there's a few things you'll want to ask to differentiate that are different in each system. And then for every history presenting complaint, Always ask associated symptoms. So have you also been getting a headache? Have you had a runny nose? Have you been sick? Have you had any joint pain? And then ask systemic symptoms. So this is really to rule out cancer. In every single system, you want to rule out cancer, and the way you do that is asking about night sweats, fever, weight loss. There are a few other bits and pieces you can add, but pick your own top 3 systemic symptoms that you ask every exam in history. Past medical history. This is the same kind of outline that I gave in the cardiovascular. So you start with specific to the disease, and then you just do a general, and then to show the marker that you're thinking that you're on the right track, you knock out some specific risk factors. So have you had anything like this before? And then general, do you have any other medical conditions? The same thing I said last time. So the first question is, do you see a GP regularly for anything? Secondly, have you ever been hospitalized for anything? Thirdly, have you had any surgeries? By asking those 3 questions, you're pretty much going to cover any medical issues that they've had. If they've forgotten to mention it in those 3, they either have dementia or it's not important. And then specific risk factors. So in respiratory, allergy is the main thing that you want to ask. You'll see allergy about 50 times throughout these slides, really important. And asthma is the other one. Does anyone know why allergy and asthma are so important and go together, and what the third thing you might ask with those is? Yes, and why? Yes. So the markers will be really impressed if you ask about eczema in the respiratory exam, so definitely do that if you can remember. Past medical history, medications is good to ask early on. So some people leave it till the social history, and I do in some systems as well. But in respiratory, it's really good to ask it early on. The main thing is because you can ask if they're taking any inhalers or taking any steroids. The other reason, though, is that there are actually a lot of medications that cause cough. So, for example, ACE inhibitors, a whole host of them. I've got a slide with my full notes that you can have a look at there. Or increase the risk of lung disease. So oral contraceptive pill, something that you probably wouldn't think to ask in a respiratory history, but significantly increases your risk of PE. So good to just say any medications at all, any oral contraceptive pill if you've got a female that's within reproductive age, and any herbal medications or supplements, just to kind of cover all your bases. But you don't need to know the names of all those medications, and you don't need to know what they cause. You just need to know that there are medications that cause lung complications, and that's why you're asking, and that will impress the examiner enough. And then allergies, should have already asked this, very important for the reasons that we have mentioned. And then family history is essentially a repeat of social history, the same kind of structure. But the 4th thing to add that is really good is anyone around you or anyone in your family unwell? So, oh yeah, my brother's had a really bad cold for the last 5 weeks and we live together. It's like, I now know what's going on. And yeah, specific risk factors, you'll also tick off the family list. Does anyone in your family have asthma? Did they have asthma as a child? Quite often you get patients that say, oh yeah, my grandma had asthma. Now that you mention it, so did 2 of my uncles. So you can kind of identify that's probably what's going on. The other thing with respiratory history is you might actually get a mum that's come in to talk about her kid, because a lot of the respiratory issues are more to do with a child than an adult, or when you're looking at asthma anyway. But you can also get an adult who's talking about their own kind of COPD. And so the case that I got when I was doing my phase 1 OSCEs was I had to take a history of a man of a COPD and then had to do peak expiratory flow and demonstrate how to put on an oxygen mask. So it was kind of a bit of a weird, eclectic history and exam. Social history, so you should all know heads from last time. If you don't, please go over it again. Make sure you hit every single one of those. They're all very important. Probably the most important that are unique to respiratory, exposure risk. So at home, where do you live? Oh, I live on a farm and my parents are farmers and we're basically in a dust bowl. Or I am a farmer and I have been working with dangerous chemicals for the past 40 years and never use any protection. I am a miner. I'm a builder and I use asbestos. So occupation is actually really important in respiratory. Smoking and drug use. Smoking, it actually looks really good if you ask it earlier on, but if it interrupts the flow of your consult, don't worry about it. And travel history is really, really important in this one. I definitely forgot it in my phase 1 OSCE, but just ask, have you traveled anywhere recently? Where did you go? Were you sick while you were there, or were you around anyone who was sick while you were there? Why is that so important? Yeah, TB, definitely one of them. The main areas you want to ask about is Southeast Asia, and there was one other one that's in a future slide. And another thing that's really good to show markers and that they'll be really impressed by is how is your current condition affecting your daily activities? So is your breathlessness stopping you from being able to exercise as much, or is it stopping you from even being able to walk 5 meters and therefore you can't do your dishes and your housework? But practice heads some more. We did it at the end of the session last time, but if you can go home and do it like once a week on someone, it becomes really smooth and really easy to do. Examination. So position, exposure, consent, and we went over last time reporting back at the end versus as you go. As you go is much easier because it gives you a structure to your consult, reminds you what you're doing, shows the examiner what you're looking for, and can also help to make the patient more comfortable because they know what's coming. But in saying that, if you're reporting back as you go, don't forget that the patient is a person, they're in the room, and they don't know what you're doing to them. So you still have to explain what you're doing and then report back the results. And even if they don't let you report back as you go, you can still kind of be talking as you go by talking to the patient and saying, next I'm going to do this, and that shows the examiner as well what you're doing. Consent, you don't have to worry about, just say, now we're going to move on to the examination. I'm just going to be having a bit of a look, listen, and feel of your arms. Your face, and your back and chest. And this is going to involve you removing your shirt. This is my notes. We'll refer back to that a couple of times throughout. You can find them on the 3rd year page if you would like them. But they're a 3rd year level, not a 2nd year level. General observation. So as you can kind of see at the top here, there's like a million things that you can look at for respiratory exam in all parts of the examination. We were lucky that in Albury last year we had a gun Resp Reg who taught us absolutely everything, but the downside to that was that we knew way too much and we didn't have time to fit it in the examination. So as a general, like pick your own top 3. The things that I would pick for respiratory around the room, you want to be looking for O2 masks, medications, which includes puffers, walking aids, and other ancillary medical devices. The reason it's nice to ask about walking aids is because it shows that you kind of care about the patient and their function and their ADLs. Ancillary medical devices covers absolutely everything. That's a word that you'll say 1,000,001 times throughout the rest of your OSCEs, ICE, and 6th year OSCEs. You can name a few, but I don't think it's particularly high yield. You can also note smokes around the room, but no one's going to like leave their smokes out on the table when the doctor's in for a consult, like you're just asking for a lecture. In the patient, you're looking for signs of respiratory distress, and there's also 1,000,001 of those. So let me zoom in. No. Tachypnea, use of accessory muscles. If they're cahectic, if their speech is interrupted, they've got wheeze, pursed lip breathing, nasal flaring, tracheal tug, their weight, peripheral edema, ethnicity to check if they might have TB or high TB risk, or if they've got Cushingoid appearance. So there are so many there, and asking all of them is not going to get you any extra marks. So again, just pick a top 3. Tachypnea is usually a high yield one, use of accessory muscles, and maybe speech and pursed lips breathing. But make your own judgment about what you think is most important. Peripheral signs, again, there's 1,000,001. On the fingers, tar staining, peripheral cyanosis, and clubbing are all high yield. Why do people get clubbing? Anyone know? Sorry? Don't know. It's long-term hypoxemia, I believe, chronic hypoxemia, which leads to buildup of carbon dioxide and some other complex pathophysiology that you don't need to know. But clubbing is actually a really non-specific sign. It occurs in a lot of different chronic disease. It's just a good thing to note. Cap refill, again, pretty non-specific, but takes a few seconds to do. Probably not that high yield and respiratory. Asterixes are really interesting. Why do people get asterixes? Yes, CO2 retention flap. So when might someone have a chronic respiratory disease but you don't see asterixes? Oh, so it's when they put their hands up like this at a 90-degree angle. You want to get them hold them for about 30 seconds to 60 seconds, and after a while they'll start doing this. And so that's a sign of long-term CO2 retention. But if they get long-term CO2 retention, then their body compensates and they don't get it anymore. So you're highly unlikely to see it, but it's good to check for. And something that looks really smooth that I would recommend is you get them to put their hands out and put their hands up at 90 degrees, their arms out. And then while they're putting their hands like that, you can check their pulse and their respiratory rate, and that way you're kind of knocking everything on their head at once and you're leaving it for the proper 60 seconds without taking time out of your examination. And then ask for blood pressure. Don't take it. Not that relevant, but good to check off the list. Central signs, moon face. Why are we looking for moon face? Cushing's, what does that mean? It means they're on steroids, yes. So you're really just checking to see if they've got a condition that's medicated with steroids. There are a lot of them. Yep.
Sorry, is the asterisks thing the same as liver flap?
As what flap? Liver flap? No, they're slightly different, but similar pathophysiology. I definitely understood it for like a week in year 3, and then it stopped being relevant, so I stopped understanding it. I don't think you need to know it. Learn it in year 3. And Horner's, what does that indicate? Lung tumour, yeah. So again, these are pretty not specific, not high yield, but takes 2 seconds to rattle off to show that you're looking at their face as well as their arms and hands. And then in the mouth, you're looking for central cyanosis. But the most high yield thing that's undervalued the most is tonsillar enlargement, because most of the time you're either going to have someone that's got an infection or someone that's got an exacerbation of asthma or COPD, which is quite often caused by infection. So having a quick look at the tonsils tells you a lot, and it takes a few seconds. So don't forget that. I definitely did, and it's very, very high yield. My marker in year 2 was like, oh, did you look at the tonsils? How do they look? And I was like, oh, they look normal. And he's like, you didn't look at the tonsils. They don't have any. They had their tonsils removed. So have a quick Google image search of what it looks like with and without tonsils, and with infected and non-infected tonsils, and bacterial versus viral infection. You don't need to know specifically, but if you have a quick look, you won't forget it. Then inspection. So look at the front of the chest and the back of their chest. If they've got barrel chest, that basically means that it's all puffed out and wide, and that's due to air trapping in COPD. If they've got any scars, so looking for any signs of any operations they've had before. They might have had chest drains in before, so make sure you look right around the side as well as on the front, and they might have had a lobectomy. So looking at the front and back for all of these things, and asymmetrical chest wall movement. Percussion, so don't forget to ask them across their arms, across their chest. And a lot of people will say, can you take deep breaths in and out through your mouth? And because the patient does that, they take a really long time to breathe, and then you have no time to get through all of your, every single lung field doing the percussion and the auscultation and the vocal resonance. It just takes forever. So just ask them to breathe normally in and out through their mouth, and that's sufficient to be able to hear anything. You don't need to percuss a million areas on the back. You need to percuss 3. So 1, 2, 3. And you don't need to do both the left and right side. You only need to listen to the right side. Why don't we listen to the left side? Because there's only 2 lobes there, and so you're not really hearing anything extra. You're already going to hear the superior and inferior lobe on the left side, whether you're listening to the back and then part of the front. And however, on the right side, because you've got that 3rd lobe, you do need to listen to the side to make sure you're covering all of the lobes effectively. But a lot of people just listen to both sides because it helps to keep it symmetrical, but it'll probably impress the marker more if you only do the right side, because it'll show that you're thinking about the anatomy. Speaking of the anatomy, so this is basically what you'll be looking at. You've got the upper and lower lobe. You do listen to 3 areas just kind of in case you miss stuff, and also because the scapula can often be in the way of the upper lobe. And then looking at the side, so on the right side, you can see there that you then get the opportunity to listen to the middle lobe as well as the upper and lower lobe. That's an odd diagram, I apologize. But have a look back through Gray's Anatomy and double check kind of your surface anatomy of where the lungs are, not for the purpose of remembering it, but for the purpose of knowing roughly why you're listening to certain areas and being able to effectively explain it to an examiner. And practice explaining to each other, have a little spiel in your head, oh, I listen to these areas of the lung for these reasons. Because a lot of the questions you'll get asked in Vivas will be very practical, so it'll be about this kind of thing. On the front, so you've done the back, you've done your percussion, your auscultation, and your vocal resonance. Moving to the front, a lot of people try and do 3 areas as well. That's really, really awkward if you have a female patient and you can't hear anything, the heart's in the way, it's just not worth it. But listening at the top can be really high yield because you might not have heard the upper lobe effectively at the back because the scapula in the way. So definitely do the same here. I wouldn't bother doing vocal resonance, but I would definitely do percussion and auscultation. And that again shows that you're kind of critically thinking about what you're doing instead of just following a sequence of steps. Yep, auscultation, vocal resonance, doing the same pattern. What you get them to say for vocal resonance is up to you. There's a few different ones. 99 is easy, and I believe is what's in tallies. Yeah, it's very straightforward. So in conclusion, offer to help the patient. They're already sitting, but offer to help them get dressed and make them comfortable before you turn back to the examiner. That will win you, there's 2 different areas that cover that in your marking criteria. So the same marks that you get for doing the entire examination, you get for being nice to the patient, offering to help them get dressed afterwards. Take a pause between finishing with the patient and beginning summarizing, and don't forget to tell the patient what you're doing. So instead of just going, I'm going to help you get dressed, okay, Mrs. Jones is a 46-year-old female, say, thank you for your time today. I'm just going to report back to the examiner. It's really great if you add in there as well, thank you for your time today. Do you have any questions or is there anything else I can do for you? No, I'm going to just report back to my examiner now. And then pause. Make sure you have at least a 10 to 15 second pause between talking to the patient and starting summarizing back to your examiner. Aside from allowing you to calm down and kind of collect yourself and get ready for the summary, it shows that you're thinking. So you don't actually have to be thinking, you just have to make the examiner think that you're thinking. And then summary, which I didn't do any notes for, but look at the slides from last week. And the same principle applies, practice your same summary over and over again. I wouldn't have a script because you have to be able to be adaptable to what's going on. For example, you might not just have a respiratory history examination, you might have a respiratory history and peak expiratory flow and putting on an oxygen mask or taking a temperature. So you have to be able to adapt it to exactly what you get on the day, but you should practice the same one over and over so that you get really good at making it succinct. And again, don't mention all of the negatives, mention the relevant negatives and put the important stuff at the start. But last week's slides will have that and I'll update these before I upload them. And that's everything. How are we doing for time? 20 minutes. Cool. We might go through lung sounds a bit then. Did anyone have any questions about any of that? No questions about respiratory history exam? Okay. With regards to breath sounds, this is something that people find really stressful because they think they have to know everything about the whole lot and how to identify them and all different types of breath sounds, and you absolutely do not need to know that. Phase 1 is about recognizing normal. So you can say, yes, this is normal, or this sounds a bit funny, but I don't really know what it is, and that's exactly what you should be doing. But if you're curious, and because sometimes examiners like to throw you a curveball, and because some people like to answer all the vivas and get straight P+, breath sounds. What is a normal breath sound? Can anyone describe it for me? Vesicular, yes. So if a breath sound was absent or decreased, what would you suspect? Consolidation. So what's consolidation? So, very literally, what is consolidation? Fluid in the lungs. So it makes sense that if you've got air coming in here, but you've got a heap of consolidation here blocking it, that it's going to sound decreased. So the thing about respiratory is it's very logical. You can very easily trace back the pathophysiology if you give yourself a second. Unfortunately, you don't have a second in OSCEs, but you're better off answering one viva quite well than answering 3 vivas poorly. So make sure you take the time and answer it as best you can and give yourself time to think about it. And the marker will respect that as well. Yeah, there's a few other things that cause absent and decreased breath sound, but the main thing that you should know is air or fluid in the lungs. What about crackles? You guys learned anything about crackles? Yeah, yep. So you don't need to know that level of detail, but what you need to know is that there's 2 types of crackles, coarse and fine. The coarse ones kind of sound like LCMs, and the fine ones sound more like Velcro. is the way that was described to me that I kind of understood it best. But go on YouTube and listen to the two. More out of interest than anything else. It's not going to probably help you a lot in your OSCEs. It's just interesting. If you've got a wheeze, what does that usually mean? A blockage. So it's just that the airways are narrower than normal, so the air can't get through as easy, and it's making a sound when it gets through. A wheeze almost always means that it's upper respiratory tract problem. So you're looking at the trachea, you're not looking at lungs. Wheeze doesn't usually come from lungs, but it echoes throughout the lungs. So you can hear it down here, but the problem is not down here. Vocal resonance. So what would it mean if you had increased vocal resonance? Yeah, which is really confusing and a lot of people get mixed up with. And I think 2 or 3 times in third year we kind of sat down in our scenario group equivalent and went, but like, what is the difference and why? And like mapped it all out on a whiteboard. So you should definitely do that at some point. Make yourself a table and fill it out yourself and copy it out a couple of times. Not necessarily now, probably a next year thing, but it is really interesting. So the reason that you get increased vocal resonance is because the sound travels better through the consolidation. Pretty simple. What about if you had decreased vocal resonance? Sorry? Yeah. So the things that sound travels well through, there's fluid, and then there's air, and then there's nothing. So I can't probably explain this very articulately, but you know how the lung is like in a vacuum and there's the whole like pressure gradient thing. So the main reason you're kind of listening for vocal resonance and the main thing that it's helping you to differentiate between, because consolidation, you'll hear crackles, you'll hear that there's a problem there, but the differentiating factor of vocal resonance is a pneumothorax. So effectively, if the lung is collapsed, you've just got kind of like a vacuum or a different pressure, and the sound isn't able to travel through that as well as it's able to travel through the air in the lung or the consolidation in the lung. The other reason is pleural effusion. So a lot of the things that we look at are going on inside the lung or inside the alveolar spaces, but occasionally you can have the problems between the lung and the pleura. And that effectively acts like a brick wall. So nothing is getting through there, no sound. So you're not going to be able to hear like anything. You're not going to hear breath sounds. You're not going to hear vocal resonance. It's basically just like nothing. And with regards to breath sounds, there are a lot of different types of breath sounds that you can learn about. There's like bronchial breathing, there's vesicular breath sounds. That's not something that's particularly high yield or you need to know. You're much better focusing on the crackles, the vocal resonance, and the auscultation, which, to be honest, is basically the same as the breath sounds. Like what you hear on the breath sounds is going to be pretty much the same on auscultation. So you're listening to breath sounds and auscultation for the same reasons, to differentiate between whether there's an infection or consolidation, and then the vocal resonance is to differentiate whether that is because of something inside the lung or whether it's the lungs collapsed or a few other pathologies that are probably a bit beyond phase 1. So yeah, this is kind of trickier stuff. It's good to know. It's not essential to know, but definitely take some time to map it out between now and OSCEs, probably after prac exam. You can definitely study for OSCEs in the last 2 weeks. That was everything that I had to chat about. Were there any other questions? Cool. Thanks, guys.